Autonomy should prime all the time. It's important to recognize boundaries for sound decision. The decision could be sound to the patient since it satisfies certain values. The same decision might not make sense to the physician. And I think a classical example we see when we did our postgraduate examination is a Jehovah's Witness, those people who doesn't want blood transfusion because it seems like a sin for them. And here, maybe this taxi driver doesn't want to pay for, it's a private setting, it is maybe 8 or 9,000, and the cap maybe represents some values for him and his family, we don't know. But sometimes there is limitation to autonomy. Patient with limited capacity and competence, those who are with advanced dementia or delirious or some psychiatric illnesses or any other illness that intervene with the mental capacity. In emergency setting, and we might assume a reasonable person will agree for reasonable measures. In case of futility of care, we might not acknowledge the patient and family wishes. And also when patient asks for unacceptable intervention, and if patient poses hazard to the others, threatening someone to kill or to injure, or someone with a communicable disease, and here we might not acknowledge his autonomy. And when we look here, this is chopping something that could be a leg. This example, it was on the media. This doctor, Dr. Bansal, orthopedic surgeon who practiced near New Delhi, he too performed amputation on beggars. Dr. Bansal belonged to a network of doctors who amputate beggars for money. So those beggars, they come and they pay and they are autonomous. So autonomy shouldn't be seen as synonymous with freedom. Freedom to choose treatment is not absolute. Rather, it is subjected to constraint and thus only involves a substantial degree of freedom of choice. So they cannot demand an acceptable measure. Like now, if a parent brings their daughter and they want to have genital mutilation, we cannot acknowledge that. And I think in each specialty there are measures that we might not acknowledge. The second principle is beneficence, do good, to act on the best interest of the patient, to promote patient health and well-being, simply helping your patient. Non-maleficence, to do no harm, to avoid anything that might endanger the patient and anything that can be labeled as malpractice. And always we weigh the beneficence versus non-maleficence. Then let us see here. This doctor, who is a physician now, he doesn't have training in surgery for the last 15 years. And he was called to see a patient who's 25 years, pregnant, 34 weeks, and she has pneumonia and diabetic ketoacidosis. She went into premature labor and maternal distress. So if this is happening here in the capital, I think all of you will agree this is a malpractice for this physician to do a C-section. But what about if the same scenario happened to this physician, if he is in a remote rural area and he is the only physician? So what will be the appropriate course? So many times we look at the content within the context. Justice. Here there is an example from, now is from the Network for Renal Transplant. Currently, this is for non-living donor. They favor recipients who have been on waiting list longest. So now they are shifting the gear. Under rules being considered by Network for Organ Sharing, kidney transplant will be given preferentially to younger, healthier patients, according to the Washington Post. So this shift is an attempt to get the most out of a scarce resource. This movement is away from saving the sickest strategy to try to get greater yield in terms of years of life saved. And here we have a lot of this issue. If we have the State Ministry of Health, if they have specific budget, so should we use it to have biventricular pacer or to get hepatitis B vaccine? So this is What about justice? They have to weigh our option, and what is the option that will produce the maximum benefit to the society. Fairness with respect to the distribution of medical resources. Who should receive a scarce medical resource, and how should we distribute them, and what is the best outcome. Then let us see about confidentiality, which is always a core. This story happened to me when I was house officer, when I just finished medical school. This is 17 years ago. We had this 23-year-old unmarried female admitted with severe right lower quadrant pain. She reported 2 fainting episodes. I think most obstetricians will say it is ruptured ectopic. Anyhow, I just finished the school. So as patient symptoms worsened, we took her for laparotomy. And we found that she had ruptured ectopic pregnancy in the right ovarian tube. Salpingophorectomy was done plus appendectomy. So the second morning, luckily we had a very good and competent medical officer, so he was well trained. He told her next day about the finding, and she admitted that she missed her cycle for 50 days, and she was worried that she was pregnant. And she asked to keep her information confidential. But the problem is her mom. She didn't know the outcome. She came and she thought that it was just appendicitis, and she felt surgery was delayed and her daughter's life was risked. And she complained للمدير الطبي. So myself and my 2 colleagues, we just finished medical school. We were upset and angry. We did all within our capacity. And now we were accused that we are not doing good care of this patient. And in fact, one of my colleagues was about to go graphic. So should we tell the story? Should we revenge for ourselves? Our reaction is emotional based. I don't know those principles at that time. If I know them, then I know principle-based action, I will keep the confidentiality, but I didn't know them at that time. So privacy and confidentiality, they go hand in hand. The difference between privacy and confidentiality can be confusing. It looks like artificial definition. Privacy is the right of individual to keep information about themselves from being disclosed. Patients decide who, when, where to share their information. When they share it, on the other hand, confidentiality, it shows how we as a health worker treat private information. So after they share it, then it is our responsibility to keep the confidentiality. We use it for consultation, if we want to use it for insurance, for billing, and we disclose it to those, the patient, those who are acceptable to the patient, and sometimes we can breach confidentiality if there is an issue of public hazard. So ethical principles, they give guidance in most of the situation. All of them, they have merit. They are not absolute. They are often in conflict. And one size does not fit all, and each situation, everybody got his size. And when they conflict, we balancing and weighing our options, logical reasoning skills, ethical theories, and sometimes we might need tools of philosophy. The same example we give that lady brought by her family for circumcision. If we get an old lady who already had circumcision done, and she's at 36 and have 6 kids, and now she wants the procedure to be redone, do we value her the same as that young lady? So in difficult moment, with all these principles and tools, in few situations, medical ethics can be complicated and messy. And there will be times when we cannot decide. So let us look at some of the Hippocratic collection. Life is brief, art is long, opportunity is fleeting, experience is fallacious, and judgment is difficult. And we have to use this difficult part, which is judgment. So we'll take the judgment scale. We weigh patient private autonomy versus community interest, and we weigh privacy against social responsibility. And on the same scale, we weigh our communicating skill and patient ability to understand, and we look at our barrier in terms of knowledge, skill, and communication and others, and also we look at their barriers. And all this through communication, consultation, counseling, judgment call, and this is to enable us to do the right thing, which will enlighten us, And those big lights are yours, and mine is this small one, but it becomes powerful when it joins yours, and thank you.